Welcome to this explainer. Okay, let's just dive right into it because this is an absolutely vital topic. Today, we're unpacking pediatric dehydration assessment and fluid management protocols. Now, if you're looking at a sick child, you know the sheer number of variables can be completely overwhelming. It's kind of chaotic, right? But what we're going to explore today is a life-saving clinical decision tree that brings absolute clarity to all that chaos. We're breaking down exactly how to rapidly assess dehydration and how those initial physical observations perfectly lock into precise mathematical fluid management strategies.
So how do clinicians actually grade pediatric dehydration in literal seconds? Well, think about this. An infant's body weight is up to 75% water. That means they can decompensate terrifyingly fast. When a child presents with potential dehydration, the stakes are sky high. And time is absolutely never a luxury you have. You need rapid, precise clinical tools that do not rely on waiting around for lab work to make critical, life-saving decisions. You need to be able to look at a patient and know immediately what path you're walking down. So here is our clinical roadmap for today. 1. Assessing pediatric dehydration. 2. The CRT mnemonic. 3. Mild, moderate, or severe. 4. Choosing the right fluids. And finally, 5. The 10-kilogram maintenance rule.
Let's start with Section 1, Assessing Pediatric Dehydration.
You know, the absolute beauty of this protocol is its simplicity. While there are a million possible signs and symptoms of dehydration in kids, your primary, immediate objective is just to differentiate the patient into one of 3 distinct categories: mild, moderate, or severe. That's it. Before you do literally anything else, you aren't trying to diagnose the underlying illness. You are strictly categorizing the dehydration level into one of those 3 buckets.
Moving right along to Section 2, the CRT mnemonic.
CRT is, hands down, the single most important clinical tool you have for this. It uses super simple physical cues to rapidly differentiate the severity of dehydration. Honestly, think of this as your clinical superpower. When you've got a crying, fussy, or maybe a really lethargic child in front of you, CRT is the filter that cuts straight through the noise of all those complex symptoms and gives you an immediate, objective baseline.
Let's quickly anchor this acronym in our memory. C stands for capillary refill. R stands for respiratory change. And T, that stands for turgor, specifically skin turgor. By checking just these 3 specific physical responses, how fast the blood returns to the capillaries, how the child is breathing, and how the skin bounces back, you have everything you need to grade the dehydration.
Which brings us to Section 3, mild, moderate, or severe.
Okay, let's hang out here for a second because this matrix is basically the heart of the whole assessment. We're mapping our 3 CRT cues against the 3 severity levels. Starting with mild dehydration. Here, the CRT is entirely normal. Capillary refill is less than 2 seconds, the respiratory rate is totally normal, and skin turgor returns in less than 2 seconds. But watch what happens as we shift to moderate. The capillary refill stretches out to 2 to 3 seconds. The respiratory change becomes tachypnea, that's rapid breathing, and the skin turgor has a noticeably slow return. Finally, look at the escalating danger signs in the severe category. Capillary refill is heavily delayed, taking more than 3 seconds. The respiratory state shifts drastically to deep acidotic respiration. And the skin turgor? The skin simply does not return. By walking systematically across this matrix, you completely remove the guesswork.
Now, to make absolutely sure you can recall this under pressure, because let's face it, it gets stressful, there's a brilliant shorthand. Mild equals CRT normal. Moderate equals the CRT 2-3 rule, meaning capillary refill takes 2 to 3 seconds. And severe equals CRT all huge abnormal. It's just a fantastic, punchy way to lock this matrix into your brain so it's right there the exact second you need it.
All right, on to Section 4, Choosing the Right Fluids. This is where clinical protocols draw a really hard, distinct line in the sand regarding treatment paths based on the grade you just assigned. For mild and moderate cases, your treatment path is an oral replacement solution, or ORS. Simple enough. But look at the other side. If your CRT assessment yielded a severe diagnosis, the treatment route drastically alters. Severe cases are treated with IV fluid just. The source is incredibly explicit here. Never oral. The severity of the physical deficits means the gut can literally no longer be relied upon for rapid, life-saving fluid absorption. You absolutely must bypass it entirely.
Finally, Section 5, the 10-kilogram maintenance rule.
20. I really want you to lock this number into your head. 20.
For severe dehydration requiring IV fluids, the protocol dictates that you start immediately with a bolus calculated at 20 milliliters per kilogram of the child's weight. This is your initial rapid intervention to stabilize that severe deficit. But once that 20 milliliters per kilogram bolus is delivered, how do you actually maintain them?
Well, you use the 10 kilogram maintenance rule. It works in sequential steps based entirely on the child's weight. Step 1. You calculate 100 milliliters per kilogram for the first 10 kilograms of the child's weight. Step 2. For the next 10 kilograms of their weight, you calculate 50 milliliters per kilogram. In step 3, for any remaining weight above that 20 kilogram mark, you calculate 20 milliliters per kilogram. You just stack these steps together to find the precise maintenance volume. It's actually a very elegant tiered mathematical formula, and it ensures infants, toddlers, and older children all receive exact, metabolically appropriate fluid volumes right after their initial bolus.
So as we wrap up this explainer, I want to leave you with this to chew on. How does simple, everyday physical observation dictate exact, life-saving mathematical interventions? We've just seen how pressing on a fingernail or observing a breath seamlessly connects to calculating exact milliliters of intravenous fluids. Mastering these simple, physical CRT cues isn't just about labeling a symptom. It is literally the very first step in a precise, critical care equation. Thank you so much for joining me in breaking down these protocols, and keep looking for the powerful connections between what you see and what you do.